Dr. Bombard is an associate professor and Canada Research Chair in Genomics, Health Services at the University of Toronto. As a scientist at St. Michael's Hospital, Unity Health Toronto, she directs the Genomics Health Services Research Program. Her work evaluates the impact of genomic technologies on patients and healthcare systems, develops digital tools for genomic medicine, and engages patients in health technology assessment. Dr. Bombard is actively involved in international policy advisory committees and serves on the boards of the American Society of Human Genomics, CIHR Institute of Genetics, and Exactus. She has received numerous awards, including a CIHR Foundation grant, Rising Star, and presidential awards from CADTH, CIHR, U of T, and the Canadian Cancer Society for her impactful research and policy contributions, for which she has been inducted into the Royal Society of Canada's College of New Scholars. Without further ado, I pass it over to you. Thank you again for being here.
Thank you. Thank you for the invitation, the lovely introduction, and for all of you taking the time out of your busy days to join me on this discussion. Hopefully, I'll just kick it off with some comments, and hopefully we can have a nice discussion after that. So I've centered my work on trying to work towards equity in cancer genomics, and I'll tell you a little bit about that in a moment. I should probably start off with some disclosures. These are the disclosures of relevance. Today is probably the genetics advisor at the bottom, which I will be mentioning on 2 or 3 slides in the middle of the talk. So that's something to keep in mind in terms of a disclosure. So without further ado, I'll kick it off. So I don't know to what extent this is a genetics and genomics audience. So indulge me with a little bit of background before I head into the equity issues that I'd like to discuss. So genomic sequencing is a powerful, relatively new test of clinical tests where we don't just map one gene or people or a few genes, but a patient's entire genetic code. And this is a technology that's increasingly being used clinically to improve the diagnosis for our patients, as well as to inform more tailored care and treatment options. So in addition to diagnosing and improving the diagnostic yield of otherwise undiagnosed patients or for rare disease communities, genomic sequencing is increasingly being used clinically also to be able to reveal risks for other inherited conditions, also predict the severity of a disease, choose the right medication and dose of a medication through pharmacogenomic variant testing, and also identify a person's risk of passing on a Mendelian or inherited condition onto their children through recessive carrier testing. And indeed, whole genome sequencing has been heralded as bringing us a step closer to personalized medicine, though for the clinicians in the crowd, we all know that you all are practicing personalized medicine every day by personalizing and individualizing your care to the patients. But when the genomicists speak about personalized medicine or precision medicine, usually they are elevating the genomic sequencing data, transcriptomics, and other kind of omic data in order to further inform and individualize a person's care. And as we're thinking about delivery of these kinds of technologies into practice, while they are poised to very much fundamentally shift the amount of patients we can now diagnose and inform their care, we have to recognize the system in which these technologies are currently being adopted and translated. And we have to also recognize a broader perspective, and that is now established that our zip code or our postal code is much more of an important influence on our health outcomes than our genetic code. In other words, the social determinants of health, the conditions in which people are born, grow, live, work, and age, collectively exert more influence on our health outcomes than our germline genetics. Racism and racialization are examples of a social determinant of health. And racialization refers to the social construction of groups as being distinct and unequal on the basis of race. And I will delve into some examples of this shortly. So this is a credit and an image that I have borrowed with credit to one of our patient and community organization groups called Rethink Breast Cancer. And I think it's a powerful first step into the story that I'd like to discuss. So all of these women have breast cancer, but while they have the same type of breast cancer, those who are racialized, who are self-identified and considered or racialized as Black, Latina, for example, have a strikingly different cancer journey than their white or European counterparts. And let me tell you why. And let's just hone in on two women's stories here. For the sake of argument, let's call the lady that's on the left, Amy, and her lady on the right, Alicia. One who is ethnically white and one who is ethnically Black. Now, Amy in yellow is 16 times more likely to get referred for genetic testing for a suspicion that cancer is running through her family, getting genetically tested for some of the common high-risk predisposition cancer genes and mutations and variations like the BRCA mutation and other mutations, because her doctor suspects that cancer might be running through her family and might actually be an explanation for her breast cancer. Now now Amy's also 16 times more likely to get a clear diagnosis from her genetic test. And I'll tell you why in a moment. Now, the flip side is also true, that Alicia on the right in the black box is also 16 times less likely to be referred for genetic testing and also less likely to get a clear genetic diagnosis that then allows her to progress and get access to high-risk intervention. The system is stacked against her in terms of getting access and getting the kinds of both access to testing, to treatment, as well as the health outcomes that follow. Let me tell you a bit why. There are disparities in how patients from racialized communities engage with cancer genetics across the clinical pathway, if you will. And this exists against a backdrop of existing barriers in healthcare writ large, including structural racism, some existing and very powerful distrust between patients and the healthcare system, and the unfortunate and long languaged history of eugenics. But against that backdrop that exists, racialized communities are much less likely to know about genetic testing, to be referred for genetic testing, and are much less likely to receive a conclusive test result, and therefore have higher mortality rates for multiple cancer types. Oops. I'll delve into each of those in turn to explain why. But let's begin with referrals to genetics and the uptake of genetic testing. So from the very first step in accessing care and who gets referred, there are disparities with respect to who is referred to clinical genetics for testing. In the US, much of this data is coming from the US. For example, Black patients were from these papers were 16 times less likely to have BRCA testing or genetic testing for the BRCA mutation recommended by their healthcare providers. And often, and what was reported, that no physician recommended was the most common reason for not using genetic services. Physician referral rates for patients meeting NCCN or clinical criteria certainly differed by race in the Peterson study, even after controlling from employment, Medicaid insurance status, as well as chemotherapy status. And this pattern was carried through with Hispanic patients who were, again, less likely to be referred for genetic testing, and often the most cited barrier for testing is a lack of recommendation from their providers. Back to our clinical pathway. Disparities also exist with respects to who gets a genetic diagnosis, and racialized communities are much more likely to receive a misdiagnosis or inconclusive test results. Let me explain in more detail. These are just two papers demonstrating that racialized patients are more likely to receive variants of uncertain significance. That's what VUS stand for. And variants of uncertain significance really is just a technical term saying that when a laboratory geneticist is looking at the genetic test variant or the gene change, they are not able to determine with certainty whether or not that genetic change is disease causing, pathogenic, or benign. And they are then they classify that test result as a variant of uncertain significance. And now here, the first paper coming from Allison Curran group is using SEER registries in California and Georgia from women diagnosed with breast or ovarian cancer, and they found large racial or ethnic differences in the uncertain results rate across both breast and ovarian cancer patients. And you can see those down these columns here. And in fact, they show that adding more genes to their gene panels actually widen the racial or ethnic gaps with regard to VUS rates or variant of uncertain significant rates. And in fact, race and ethnicity, as well as date of diagnosis, were significant predictors in getting VUS results. Now, the second paper from a systematic review led by Salma Sheikh in my lab was evaluating the clinical utility of genomic sequencing, which I introduced off the top, and actually also found significant differences in the diagnostic yields and the rates of VUS among the European patients and those who were classified or self-identified as non-European. Now, this is mostly driven by long-standing Eurocentric biases in our genetic databases that play huge roles in driving these disparities. So when those laboratory geneticists are evaluating and making interpretations on a patient's genetic test results, what they're doing inherently is comparing that genetic test result of that one individual patient to a reference database or a reference database or genomes. But those genomes are largely, that reference database is largely made up of genomes of individuals of European ancestry. And you can see the proportions of individuals of European and non-European ancestry has not really shifted over time, over decades. And this missing data from unrepresented ancestral populations really limit the opportunities to identify new disease associations and expand our understanding of disease etiology, but also have important clinical consequences. And these biased databases, unfortunately, have led to misclassifications and can lead to misdiagnoses and unnecessary treatment and surgery, which literature has actually shown to be higher among minority ancestries. And in fact, the rate of misclassification has been found to be higher among minority ancestries, again, in Jeffrey Whitesell's paper here in a prospective cohort of hereditary cancer syndrome patients and their variants. They're adjusting for both lab, year, gene, sex, and current classifications, and even were adjusted for multiple hypothesis testing. And this New England Journal paper actually identified multiple persons, all of African or unspecified ancestry, who've received pathogenic variants for hypertrophic cardiomyopathy that were actually based on misclassified benign variants. And in the last paper, again, led by a graduate student in my lab, Chloe Mighton, showed that actually receiving these kinds of uncertain results in general actually have important clinical impacts on both patients and providers. And in fact, receiving these VUS or uncertain results lead to higher levels of genetic specific concerns among patients who receive these VUS. And that there are instances, in fact, where providers themselves are treating these VUSs, these uncertain results, as pathogenic disease-causing results, leading to unnecessary treatment and surgeries, when in fact, the guidelines indicate that medical management should not be altered at all based on these uncertain VUS results because they're not confirmed to be pathogenic, and therefore medical management should be consistent with their background, personal and family history. And in fact, the systematic review and meta-analysis had also shown that it is actually how the providers communicated with their patients to explain the interpretation and management of these variants of uncertain significance that actually contributed to patients' psychological responses. So overall, what we're hearing from the data and the literature is that we've got reference genomes and the reference data sets that are skewed towards European ancestral groups that lead to a higher rate of misclassification, as well as variants of uncertain significance among individuals of non-European ancestry. That could also lead to inappropriate management or unnecessary treatment, as well as significant distress and an ongoing distress that among these participants who receive these uncertain results. Now back to our pathway, our clinical pathway. So clearly, if you can't get access to a genetic test or get a clear diagnosis from a genetic test without a confirmed molecular diagnosis, then access to high-risk screening and interventions are also limited, and therefore it's not surprising that long-term health outcomes are actually affected too, with higher rates of mortality from multiple cancer types among breast, colorectal, among racial patients. And this, of course, in general, it's been well established that there are racial disparities in cancer screening, treatment, and survival. And this is very much highlighted by much of the data that comes from the US. And clearly, cancer death rates, unfortunately, remain higher. And even though they're falling a little bit, they remain high among Black patients in the US. And in Canada, we don't do a great job of collecting a lot of the race or ethnicity-based data. So a lot of that data is emerging only slowly now. So it's no surprise, therefore, that pattern is now seen among hereditary cancer syndrome patients as well. In this Chapman-David retrospective chart review, all patients undergoing genetic counseling for hereditary breast and ovarian cancer, there also report that non-Hispanic Black patients were more likely to die of cancer. In the next study, in the Cragen paper, again, lower oophorectomy rates were observed among Black BRCA mutation carriers, even after controlling for socioeconomic status. And this disparity persists up the chain too in clinical trials where non-Hispanic Black and Hispanic patients are significantly underrepresented in clinical trials. However, there's a paucity of evidence on the influence of social determinants of health and race in particular on disparities in cancer care in Canada, especially in the area of genetics. There are only a handful of Canadian studies that have highlighted the existence of these disparities in cancer genetics in Canada. And here are the three. The first one showing the Armel study looked at a population of women with serious ovarian cancer diagnosed between 2010 and 2016 from the Princess Margaret Cancer Registry. And again, they found that majority of women who were referred and attended genetic counseling appointments were of self-identified white ethnicity. The Brawley paper from Casbenton Schrader and Sophie Sun from British Columbia, they looked at population of women with index patients who were tested at their hereditary cancer syndrome program that covers the whole of British Columbia and the Yukon. And they show that, again, the majority of that there is underrepresentation in terms of non-European ancestral communities actually getting cascade testing among their publicly funded hereditary cancer program. And Kelly Metcalf and Stephen Narod's team in Ontario from the Ontario-based study also looked at the same issue in terms from a provincial-wide study that they were running outside of the of their clinical setting, and have actually also come to the same conclusion that white women were more likely to have undergone genetic testing than women of other ethnicity, and that was a significant difference. And there is a paucity of data that is showing this, but certainly we don't have a picture of these disparities across the continuum of care, and we understand, I've tried to explain how one very much leads to another. So in Canada, we really are trying to be in a position that we can measure it from across the continuum of care, but across the entire provincial setting. And so these handful of studies very much existed to highlight and highlighted these disparities in cancer genetics, but they are limited to a few selected clinics and programs, and certainly haven't addressed the disparities across the entire continuum of care, from referral to diagnosis to subsequent risk-reducing management. And of course, a lack of Canadian data represents a major gap that impedes action. And so work that we've just gotten underway with the grateful support from CIHR and the Ontario Institute of Cancer Research, where we're aiming to identify and characterize what racial disparities exist along the continuum of care at a provincial level, so that we can provide evidence on which populations are experiencing these disparities, at which juncture in the care pathway these disparities occur, which is currently unknown. And what we're trying to do is take a mixed methods approach, first by starting with qualitative interviews with patients who are racialized, with providers that serve cancer in the cancer genetics ecosystem, as well as health system leaders who, again, make decisions for the Ontario cancer care system. And what we're trying to understand is, from a patient's perspective, as well as from those providers who serve racialized patients, what the lived experience and practice patterns and perceived barriers and enablers are, and potential solutions that some clinics or some communities have adopted in order to overcome those disparities and access issues. We're trying to get a very rich contextual description of those lived experiences and those patterns and potential insights, to then build out a very large approach to how we then go and do a retrospective chart review across the province. And here we are going to capture data from patients who refer to genetic services and or receive genetic testing for hereditary cancer across the population of Ontario. And we are going to be then tracking and extracting data around the uptake of their services, in terms of having uptake of genetic counseling, of genetic testing, the recommendations for management, the diagnostic and yield, and the VUS, uncertain yield, across and by race and ethnic group. We're going to then link their data to the provincial administrative databases for the population of residents who receive genetic testing for hereditary cancer, so that we can evaluate the healthcare utilization, their cancer outcomes, and non-cancer outcomes as well. I'm not in the business of just revealing problems. I'm like to try to move towards solutions. So this is very critical evidence that we need to lay the groundwork for subsequent work to then co-design interventions with members of the racialized and ethnic communities that are experiencing these disparities, as well as decision makers and healthcare providers, in order to optimize access and delivery of genetic cancer services across Ontario. We have been fortunate to partner with a wide variety of clinics and labs who've been involved in this project, that are serving a representative sample of clinics and labs serving diverse communities, broad catchment areas, and from each region of our province in Ontario. But already there is data that's emerging outside that we are able to leverage to understand what is happening in Ontario in terms of the barriers that are experienced for hereditary cancer genetic testing in Ontario. In Ontario, as there might be across other provinces, there are eligibility criteria for testing for hereditary breast and ovarian cancer that have recently actually been updated, spearheaded by Harriet Feilader and Kathleen Bell. And to determine if patients meet this criteria, often the family history is a requirement to be known in order to get a genetics consult. And this is because usually if there's a strong family history that meets the criteria, then the province will pay for genetic testing. But at the patient level, the questionnaire that is being used to determine this family history, or even at a patient level, for a patient to even be aware of the disorders that run through the family, actually could exacerbate disparities even among racialized or minoritized individuals. And this is because data has indicated that often, and even from the lived experiences and from the data, qualitative data to date, we're learning that there are inability to fill out the questionnaire about family history because of low literacy, because of language barriers, or just a lack of awareness of how to complete the questionnaire. But just stepping back a bit from a higher level, we've also learned about the limited capacity or communication amongst family to even gather the required medical family histories, because often there might be some myths or some expectations that health and disease is not actually something that is often shared within families. And that could be actually exacerbated among certain racialized or minoritized groups. Further, there might even be a mismatch between what a medical family pedigree is considered and what cultural family structures are used, especially when blood relatives are not the only relatives considered in a family, or if there is polygamy or consanguinity. This leads to the provider making eligibility decisions on the limited data that's reported based on personal and family history, and some patients don't even complete it. And with no one following up, they fall through the cracks and don't get access to genetic testing. Some clinics have recognized this barrier and restructured their workflows, whereby they send the questionnaire after the initial consultation, or even try to complete the questionnaire with their patient, which can mitigate most, if not all, reasons that are listed in these disparities. Now, what we're learning from the US is several barriers and interventions that have been proposed, and certainly and I've already described some of the health from the health system and provider level. The family history form being an issue, the fact that eligibility criteria are based on the family history form, which creates problems for some individuals, and can be exacerbated among racialized families and communities to even be able to fill out this form. Of course, among the providers, familiarity and even awareness with and having cultural humility and having and delivering cultural safety can be its own barrier to care. And some of the interventions described as cultural safety education, point of care family history tool, assessment supports, and even just completely removing the need for these requirements to even have criteria, and even requirements to even have referrals being made by family docs altogether, and let patients to even self-refer to cancer or genetics clinics writ large. At a patient level, certainly this is being echoed by the interviews that we're conducting now, but there is a low level of awareness and appreciation of genetic conditions, a low level of discussion of family history of conditions within family. And again, a reinforcement of the lack of ability to finish these and complete these family history questionnaires. And just the limited ability to actually just take care of their own health, and the ability to take off work and find childcare alternatives. And some of the interventions that have actually been put forth by both these, the research to date in the US, but also in some of the community conversations we've had in Ontario, are actually bringing the clinics and offering pop-up clinics at community locations, as opposed to what is otherwise inaccessible academic tertiary genetics clinics that are often in urban settings. And even the consideration of digital tools, which have been shown to improve knowledge among patients, to improve access to care, and even adherence to surveillance and prevention recommendations. And on that note, there has been a push to use digital tools. And certainly after the pandemic, virtual care and digital health tools have certainly emerged. But they are certainly essential in accessing genetic services and even optimizing the delivery and advancing equity. Digital solutions can to reduce disparities by in access by deploying genomic services in diverse and underserved settings outside academic research setting, and even engage broader communities of healthcare providers, and increase representation of broader ancestral groups and communities in healthcare and the data systems that we use in the databases that we use to interpret genetic results. There was a systematic review conducted both by my lab and Robin Haim's lab that actually show that digital tools in genomics have actually had favorable effects on patient outcomes and efficiencies. In fact, all but one of the tools that were gathered as part of the systematic review had showed a significant improvement across all of these outcomes in terms of knowledge and patients' knowledge and understanding, the decision making, in supporting their decision making in terms of genetic testing, engaging patients in their care, in supporting the psychosocial well-being in terms of emotional outcomes, in terms of distress, anxiety, and depression, as well as even trying to, again, increase adherence to screening and surveillance and management changes, as well as trying to support family communication around disorders and the need for genetic testing. I'm going to just provide one example with Genetics Advisor, just to illustrate the points of some of the systematic review data that I've just described. So the Genetics Advisor is an example of one of these digital tools that is a patient-facing digital tool that is meant to scale the delivery of genetic testing and empower patient in their cares. And one of the randomized trials that we conducted on a prototype version of this Genetics Advisor had with cancer patients, where we had cancer patients recruited from the Greater Toronto area that were suspected to have hereditary forms of cancer, but for whom we could not confirm, for whom they received inconclusive results. They were recruited to our randomized control trial to test the efficacy of the Genetics Advisor. And for those who were randomized to the intervention or to the control arm, they had used standard of care genetic counseling to come to a decision with regard to their genetic testing and the results they want to receive. And those that were randomized to the intervention arm used the Genetics Advisor as preparation before speaking to a genetic counselor to reach a decision around genetic testing and the type of results they wanted to receive. And at the conclusion of this trial, we found that, in fact, the intervention arm that used the Genetics Advisor before speaking to a genetic counselor had significantly higher levels of knowledge around genetic testing and the types of results that could be learned. And that was sustained across multiple time points that we assessed that knowledge attainment. And further, those that were in the intervention arms on average spent significantly less time with their genetic counselor after using the advisor, on the order of 50% reduction in consult time. And we also tried to understand what was going on between the patient and the genetic advisor across both arms. And a genetic counselor at our lab, who has now graduated, Salma Sheikh, she had recorded the audio. She recorded the audio sessions between the patients and the clinic and the genetic counselor across both arms of the randomized trial to delve deeper into how the digital tool, the Genetics Advisor, had affected those conversations. And what she found through qualitative analysis of the transcripts of those audio recorded sessions between the patients using the advisor and then speaking to their counselor versus just the patients that spoke to the counselor, what she had found qualitatively was, first and foremost, if you looked at the transcripts, the talking time and the talking amount was much higher with the intervention arm. Whereas with the control arm, the patients were pretty much talked at by their genetics advisor, and the talking time was limited to a few words or a couple sentences for the control arm. So that led her to conclude that it promoted dialogue. But she also saw that the nature of the conversation and the content of that talking time that was by that patient in the intervention arm was often much more informed, using the educational data or the educational content that was actually drawn from the genetics advisor, from the digital tool, and brought into that session. So that led her to conclude that It promoted patient engagement during the course of the session, but much more informed dialogue. Further, when she looked at the content of what was being discussed by those patients, she noticed in the intervention arm that the patients were actively trading off and weighing off the benefits and risks and harms and benefits that were actually described in the digital tool in very much active way versus the control arm, leading her to suggest that the digital tool actually facilitated deliberation around patients' preferences, as well as their perceptions of benefits and harms in a hypothetical manner. But she also then found that those hypothetical benefits, harms, again, in the intervention arm, those patients were then applying and personalizing those harms and benefits as they affect their own personal experiences and personal circumstances. Again, leading her to conclude that these kinds of digital tools not only promoted informed dialogue and enhanced preference-sensitive deliberation, but then deepened that personalization of those potential risks and benefits in their own lives to then lead to a shared decision to a decision on whether or not they're having testing and what kind of results they want returned. And in fact, as the clinicians on the call might actually perceive and be aware that, in fact, informed dialogue, patient preference sensitive deliberation, and deep personalization are fundamental pillars of patient-centered care, suggesting to Selma, for Dr. Sheik and her and our collaborators, that in fact these kinds of digital tools can advance patient-centered care and empower patient in their care. So back to our study. As I mentioned, we will be learning from the results of our qualitative analysis, as well as our provincial chart review, as to which communities and which patient and communities are experiencing these disparities, along which point of the pathway, of the clinical pathway, those disparities are experienced, and then also use that to then work in a partnered way with those communities to co-design and then test potential interventions to address those disparities. And of course, we'll be using design thinking, where we're going to partner with those patients and those communities experiencing the disparities and ideate, test prototypes, and define and see if we can move the needle on some of the disparities at some of those interventions, and along those pathways. But I would be remiss without reflecting on the fact that our clinical enterprise is so in genetics and genomics is so intimately linked and inherently linked to research. And we need to be considering a paradigm shift in our scientific enterprise, because, as I've mentioned, those variant databases that we're using to interpret participants' genetic results and patients' genetic results in terms of the downstream implications on their healthcare are very much an upstream problem in terms of who is captured in our databases, how we conduct our research, and the representation of those databases in our research enterprise writ large. And so concurrent work that we're actually wrapping up now is actually trying to provide some best practices and some recommendations to the research community of scientists in trying to increase the representation in both clinical trials in cancer and in genetics, as well as in the reference genome databases and who's actually participating in the research writ large. And so clearly cancer genetics and genetics is just one area where there's a huge amount of research and lessons to be learned in terms of trying to conduct equitable research. And so what we thought would be the first step is to actually go beyond cancer and beyond genomics to actually understand what are the effective strategies in engaging patients and underrepresented communities in research. And so we amassed the evidence base to look at those papers and research practices to try to further engage underserved or racialized populations in genomics research outside of cancer. The interventions that would be used in terms of strategies, in terms of methods, in terms of research practice to appropriately engage those underserved and racialized communities. And we're trying to draw any strategies and contextual factors and also the outcomes of those engagement strategies in terms of the kinds of impacts they had on their research enterprise. So this is just the Prisma diagram and the PICO in terms of what we captured and how we conducted our systematic review. And here is just a quick overview of those research and those strategies. So we ended up reviewing and capturing an eligible papers of rather 76 papers that were included to date. 59 of those 76 were actually conducted in the US. A quarter of those papers actually focused on engagement strategies with African American communities. And 34 of those studies actually had data that they were reflecting on what actually was the outcome of using those engagement strategies and evaluated some element of their engagement approach. I think what I would just end off here is just reflecting on some of the thematic analysis from the data set so far. And in the purple center, really at the core of what we learned was fundamentally research that is conducted needs to be conducted with underrepresented communities with them as partners and not on them or for them as third-party consulted individuals and community members of that research. And that fundamentally that the principles of transparency and accessibility, making sure that participation is offered at local community events within working times, outside of working hours, that materials need to be at low literacy levels or accessible literacy levels in multiple languages, and that honorariums and other benefits and mutual benefits need to be considered and built into the study design, and fundamentally that those studies partner with the leadership of those communities and community members themselves, and they have equal status on the research team and serve as part of the governance structure and the research team itself, and very much are part of the governance and control over the data, the sample, the interpretation of those results. And that beyond just the research enterprise, that we are working towards capacity building so that we can provide resource and high quality outreach for community members to participate in research, and training opportunities for how to conduct their own research and participate in as active participants in those research and partners in those research endeavors. And that first and foremost, that engagement is very much built on trusted, meaningful, and mutually beneficial partnerships. So I'm just cognizant of time, so I'm going to wrap up with a quick summary and some acknowledgements. So in summary, there certainly exists and continues to exist structural and systemic level barriers that disproportionately affect racialized patients, that these race-based disparities can actually occur at each and every stage of the cancer genetics pathway. There needs to be more efforts to characterize these disparities and work towards community partnership and engagements that need to be prioritized in order to create and test meaningful interventions. I certainly stand on the shoulders of giants, and those giants are pictured in the middle here, which is the members of my lab and research team that conduct this research in collaboration with our co-investigators and collaborators and funders. And I also quickly want to thank the members of the Equity in Cancer Genetics team that include, of course, the clinicians, of course, the equity scholars, but importantly, center and partner our patient and community organizations and health system leaders and lab directors that can help with moving some of the interventions and are committed to moving some of the interventions that we build and co-design with our membership and community members into practice. So with that, I will stop sharing and open up for questions and discussion. Thank you very much.